Awesome. Anybody going to work on the blood bank drive? Good. If any of you ever get an opportunity to actually work on the drive, I would highly recommend it because anything on patients, all about, kind of make them feel more comfortable about getting blood. You can see the safety mechanisms that are in place. It's a good thing to do. So I recommend it. What I did is I prepared this presentation for you, and I did a couple things to do it. First of all, I went around the lab and I said, what would you like the nurses to know? I'm going to talk to these nurses at Fort Kent. What do you want them to know? Then I went to the nurses in the hospital. What would you like to know about the lab if you were a beginning nursing student and, beginning nurse? So this came out of that, okay? So like I said, I'm in charge of the blood bank. I also do some grant writing. So you might see, things from time to time that Carrie does. I might be behind them. So I'm kind of proud of that little part of what I do too. And I've also, one of the things that I've done is I've taught for about 14 years at the University of Maine at Prescott. I'm not currently teaching right now, both in science classes and as well as in the medical laboratory technician program. Taught at NMCC as well. So let's start. So we're going to learn a little bit about the lab. How many of you have been in a lab? I'm impressed. Good for you. Well, we're going to learn about the lab. I want you, if you haven't been in a lab, this is going to be your first introduction because you're going to be walking into the lab, seeing what the lab actually looks like. If I was a nurse, I'd want to know, hey, what's this lab all about that I have to work with. And so I want to let you know who works there, what we do, all about some of the common tests and everything. And then what we're going to spend a little bit of time on is the key area that the lab wanted you to know about, and that is about specimen collection. And then we're going to talk about the key thing the nurses students, the nurses at Carrie wanted to know, wanted you to know, and that's about the interactions with the lab. Okay? How do I relate? Who do I go to? What's the process? Okay? Because we're all in the same team, healthcare team, and so we need to know how to work together. And at the end, any questions you have, feel free. I'll do my best, and if I don't know the answer, I can certainly get back to you later, get to your instructor, and they can give you the answer. So, if you're taking a peek at our lab, first of all, what you might not realize is it's complex. It's not just the lab. You walk into the lab, a lab has many different departments, many different subspecialties. So the first part of it is kind of like the patient area. If you're coming to Carey Medical Center, and how many of you been to Carey Medical Center? So, wow.
Yeah, we do a lot of clinical work.
Okay, so you've gone by where I work. You didn't say hello.
Actually, you guys don't stand out your area too much.
No, we're kind of hidden back there, so that's it, yeah. But you saw the waiting room, okay? You saw where patients go, they wait, and there's a little room off that, the registration. And then if you go within, open the door and stuff, and we'll go into the lab and we'll see what it looks like in a minute. We have our phlebotomy staff, okay? So the phlebotomists do all the blood draws, except when they can't. And then it comes upon us, who are the lab techs, to do the blood draws. And second shift, we do blood draws. And third shift, we're the only ones doing blood draws. So depending on your shift, depending on, if patients are hard or whatever, we all work as a team. But we have people that are dedicated to that, so we'll go over that. Now, the lab itself, we're going to go into each one of the departments and kind of go over the basic tests, what it's all about. We have urinalysis, coagulation, hematology, clinical chemistry, blood bank and serology, and microbiology, histology, and cytology. Okay, now technically, if you want to get really picky, in a bigger hospital, serology would be by itself, and histology and cytology would be separated as well. In smaller hospitals, they can all come together, and just for ease of bunch of offices. So here's a sign, you're gonna come into the lab, here's our receptionist's tour, okay, that you meet right outside the waiting room. And, oh, this is not, maybe, are the lights okay here, or should we, you guys see down the back? Everybody's kind of fuzzy. This is Tanny Ballard, she's one of our phlebotomists, and so she opens the door and greets every patient as they come in. Here's Darren. Darren was drawing blood for us for a while, working here as a phlebotomist. So this is the drawing room right here. And Darren is now a PA, or almost a PA. He went on. Now, when you come in out of that drawing room, what you see within the lab here is this area is an important area. This is Christy Anderson. And Christy is taking samples. You see the trays right beside her. She's basically probably just come back from the ER. And she's got patient samples in her tray. What she is doing is she is taking each sample and she is putting it in the computer. She has to enter who drew it for a blood sample, or if it's a urine sample, who collected it, and what time they collected it. And then she also has to enter the time it was received right there in the lab. Okay, so we can track samples, okay, if there's ever an issue. Okay, so those things are important. They get logged in, and then once they're logged in, they're all ready to be automatically processed. And you'll see how that works in some other areas. So, at Cary Medical Center, we're so busy, we do 500,000 tests a year, which we think is quite a bit. You know, if you're looking out through the lab, and by the way, just because I'm showing the Cary Medical Center, this is typical for all small hospital labs, okay? Go, when you're in a hospital, when you're working in an area, and if there's a lab right there, go see the lab, check it out, you know, familiarize yourself with it. Looks like a lot of stuff there, but this is one big room, and then off it are other rooms in other departments, but most of the activity goes on in this room. Incredibly busy place. Here is walking around this room, you can see Kathy, she's working here, she's doing an erythrocyte sedimentation rate. And anybody know what that test is? ESR. Anybody hear of it yet? Basically, it's a very general test, not specific. It's looking for inflammation, and it's measuring the rate of the fall of the red cells in an hour. So, which are erythrocytes. So she's setting it up anyways, but this is hematology. We'll look at it later. This is looking into our chemistry department right here. You can see some of the instruments, the centrifuges, and a couple of our instruments there. That's an ugly picture of me in blood bank. So we'll scoot over that one. Here's Nancy. Nancy's in micro, and we'll go into this a little bit more later too as well. So one of your jobs is, if you're not directly collecting a sample for some pus off with somebody, or you may be assisting a physician doing that, you know, it varies. But everything gets plated on petri dishes, you know, on different types of media. And then what happens is at a bench like this, the lab tech has to take those, and they've been streaked for isolation, and they have to figure out, are they significant? Could they be causing the infection? And work them up if they are significant. And also right down there, right directly in front of Nancy is some plates where if they are significant, they'll set them up for antibiotic sensitivities. So figure out the right antibiotic to use. This is histology, what it used to look like. We've rearranged since then, but what you see right there, right here is a tissue processor. Because what happens is surgical specimens, the pathologist will look at them and will figure out what sections to take. And then those tissues get put in this processor right here, and they get actually dehydrated and embedded in wax. And then what they do is the histotechs will slice them, those wax blocks, 1 cell thick, mount them on slides, and they get stained in different ways for the pathologist to look at. Here's Joan McElwain, she's our lab manager. One of our pathologists, he's retired now, Dr. Boone, but I'll show you our current pathologist. So who works in the lab? We've got our office staff, we have phlebotomists, as I mentioned, they are just blood drawers. But notice that they're OJT, they're on the job trained. So we have staff that knows just our procedures and that we train. You don't have to go to school to be a phlebotomist. There are some schools across the country though, and programs across the country for that, but we don't do that in this area. All the hospitals are trained in the hospital, all the phlebotomists are trained in the hospital. We have MLTs, and what I want you to realize is that the lab profession, it's a lot like nursing. It's just a different pathway. So you have 2-year nurses and 4-year nurses. We have 2-year lab techs and 4-year lab techs. So it's the same level and the same intensity as somebody that's done a 2-year nursing program, they've done everything you've done, compacted, not quite the depth, but shoveled right into them. Same thing happens to our 2-year MLTs, they have everything shoveled right into them in 2 years. It's a very intensive program. So, we have an MLT program at the University of Maine, Prescott, 2-year program that a lot of people will go to. In fact, it supplies a lot of the lab techs in Aroostook County and in the state. And then there are people like myself who are 4-year professionals. I started out at Orno in medical technology, and then I went to Bradley University because I got married, not because specifically chose Bradley, but it was a wonderful school in Illinois, in Peoria, Illinois, and that's where I got my degree. You can specialize in the lab. So we have people that, and even some labs, they don't become MLTs and MTs, they actually, maybe they're microbiologists and then they go into lab medicine. So there are people like that in the lab as well. But there are specialists you can go beyond. For instance, I could be a specialty in blood bank, and so I would be an MT SBB, specialist in blood bank, if I went on. So people specialize. And our master's degree, and then we have our pathologists, which are, they're medical doctors. So, to be a med tech, what you have to do is you have to perform all the tests. That's what we do. We're test performers, but we also know everything behind the principle behind the test and all the background. We have to be able to see what's normal, what's abnormal. Kind of troubleshoot a lot with computers and instruments. So, for instance, every now and then we have to watch sodiums and potassiums in our lab. Okay, and just because they're not as stable as some other things. So you have to be able to recognize trends in your patients, like, oh, wait a minute, maybe my patients they're not as high as they should be, my normal patients. And med techs have to be able to do that. They have to be able to fix that. Now, as far as a player in the healthcare field, 75% of the decisions that the doctor makes are based on what we do, which is huge. I mean, think about it. You can evaluate somebody, you can take their vital signs, you can look at them and give them how they're feeling today and everything there, but you can't see what's going on chemically in their body. You can't see if they're really truly anemic or all kinds of different things. So the lab tests are needed for that. We provide some indirect surgeon assistance, for example, somebody's in surgery and they're removing a malignancy, they want to make sure they got it all. Or maybe in surgery they want to know if they need to have blood, they want to check their CBC or check their chemistries for some reason. We help with treatment, For example, antibiotics, we're the ones that tell the doctors which antibiotics are gonna work, which is, it's huge. We also, monitor treatment, in other ways, and I've got some examples up there. Glucose, huge, you know, you guys are gonna be taking, point of care, you're gonna be doing glucose testing. But if it's abnormal, what do? You draw their blood, you send it to the lab, and you confirm it, okay? Because a point of care instrument is not as accurate as what's in, you know, what's in the lab. They have their drawbacks. And your instrument might be malfunctioning, you never know. So, but we monitor different tests. ESR is that erythrocyte sedimentation rate for arthritic patients. Disease progression monitoring is an important part, and also certain drugs. A lot of drugs, we have to actually, they're within a narrow range, and you guys have, you've taken that part of your training, right? So you know that some drugs have to be tested via the blood. And there are other tests, other types of drugs and medications that, for example, heparin, you have to monitor it with a PTT, okay? So this is an important part of what the lab does. And yes, we do drug testing and all that kind of thing for screening for people. And one of the things that, like I said, I'm in charge of is blood services. That's a big deal. So, as a nurse, you want to know who's in charge. This is one of the questions and one of the things that my nurses at Cary wanted to know. So, if it's a testing issue, you're going to go to the people doing the testing. If it's a drawing issue, you're going to go to the people that did the drawing. You know, oh, Mr. Smith in room 305 needs his troponin done right now. Are you guys coming over? You know, you're going to call. We don't mind. We don't mind, you know, if nursing calls us and follows up, because sometimes things slip through. You know, our orders can get lost. You know, we're all humans and we're all working together. So, personnel issues, if you have a problem with somebody that works in the lab manager is the person to address. You know, if you see something that somebody that's coming out and tending to one of your patients and maybe they're unsafe, or you don't, you know, maybe they went into a room and they didn't gown up when they were supposed to, it would be your lab manager. Also your infection control in that example. Pathologist role is probably you won't be dealing with a pathologist very much, because they're really there to support the docs. They're there to give them advice, help them in treating their patient, okay? They also oversee the lab as far as the quality. So one of the things that we do, and I'm part of a team, we go to other hospitals and get to inspect them. It's lots of fun. But anyways, our pathologist is in charge of that, okay? So they're the leader of our evaluation team. Okay, so what we're going to do is we're going to go into each of the departments, so you know a little bit about it, okay? And if you've had blood work done, you know, maybe you can relate some of it to what I'm going to go through. So the first department is hematology. Heme is blood, and ology is the study of, so it's the study of blood. And the most frequently ordered test, one of the ones in the lab, is the CBC, the complete blood count. Have you guys studied this at all in nursing, over the CBC? So this is like review. I'm impressed. So the sample, and this is one of the things that nurses tend to not know or forget, is a purple top, or an EDTA. That's the anticoagulant that's in there. It keeps the blood from clotting. And the way it works is it binds calcium. anyway, I'm sorry, I just realized that, which is needed for the blood to clot. So these are purple top tubes. So when you see them, you take a whole blood, these are, the ones that you would use. Now, you guys all know you're gonna have to draw blood, right? Our ER nurses, they, when they start an IV, they help us out, so you don't have to stick that patient again, because if you're a patient, you don't want to get stuck again. And so they'll go ahead and draw blood out after they've started the IV.
Most of them, in the facilities that I've been in the area, draw blood when they initially start an IV, especially the ER and the ICU.
Yeah.
Not so much med-surge, I don't know about Carrie, but here I know
Yeah,
med-surge doesn't.
no, they don't tend to as
And,
much.
yeah, and then, if they have a central line, they, especially the ICU nurses will draw off the central.
Exactly, exactly.
Report CAT.
Yeah,
That nurses have to, wellness can't draw from a.
they
central line,
cannot,
right?
no,
Right.
and neither can a lab tech,
Right.
no. And the other thing is that most lab techs don't do is arterial sticks.
We did,
Correct.
we actually did, bottom system too,
Okay.
and went through training.
If you go through the training and you keep yourself updated, there's very few people that can do that, so it makes more sense to have specialized people that do ABGs.
That's usually the.
Not all nurses do that because they can't
The
stay
nurses
up
wouldn't
on
do it, only the sponge and the, respiratory techs would do it.
Well, our respiratory techs do it, and a certain number of our nurses, and we have one lab person.
Yeah, it all depends on the
that does it.
facility and
Yeah,
the things in
depends
the
on the
room.
facility. So, yeah, we all have our roles, don't we?
Yeah.
So, with the CPC, what you wanna have happen in that EDTA, is you wanna have blood be as much like your blood in the body as possible, because you are measuring cells. And you want the cells to have that same size and shape. And one of the things that's important when you fill these tubes is that you fill them correctly. Now, that's not a problem when you do it certain ways, because they're vacuum tubes and they only draw in the correct amount. But you still need to know a little bit about them. If you underfill them, what happens is the red cells actually change size. Kind of interesting, right? Because of that balance of the anticoagulant in them. If you fill them too much, then you've overcome that, and you could actually get clotting, okay? And all of your tubes need proper mixing. And what we mean by mixing, you don't want to do this. Anybody know what would happen? You break the cells all apart, okay? But oftentimes I see nurses that are drawing from IVs, and they just fill them up and they just plunk them on the counter, okay? You have to invert them like this. Mix them 8 to 10 times, gently. Okay, and I know you're busy, but maybe you could be doing something else while you're doing this, okay? Because you have to multitask, you know, and you guys are gonna be kings and queens of multitasking, more so than me. So, mixing is very important. Having the right amount is very important. So, what can you say? So, problems with good CBCs, and don't be upset if you do the sample and we come back and we say, I'm sorry, we're gonna need another sample. That was hemolyzed. Well, I wanted to bring a sample that was hemolyzed, and I actually called them up because I was off yesterday, and I said, oh, can you find a hemolyzed sample? I wanna show them. They didn't see one. Basically what I'm gonna show you, and I'll pass it around, just don't open it up. And you can look at the barcode, okay? And we'll talk about that later, okay? Well, I'll mention it now. First of all, this right here is, I barcoded it and put a troponin on it, okay? Anybody know what troponin is for? For heart attack, to be able to evaluate. Part of the evaluation, not the whole thing. But the tests are barcoded, so the instrument recognizes it by the barcode, knows it's that test. Once you saw Christy putting it into the computer, once that's done, the instrument will know, you put it on the correct instrument, of course, it knows the correct test, that barcode. And where it says CPSI test, that's the patient name. We have the initials of the person that drew it and the time. And the lab test is a number, it's at the bottom right there. And there's also the top number over here, is their hospital number, okay? So anyways, this tube, and I know you can't absorb all that, but this tube right here is pretty normal, okay? Hemolyzed, when you look at it, once it's spun down, by the way, what's the liquid part called? What do you think in here? Plasma. Because this is a green top, and we'll go into that in a little bit. It has an anticoagulant in it. So once it's spun down, the liquid's called plasma. For a red top, if it's spun down, the liquid's serum, okay? But this one right here, and you might not, obviously crossed out the patient name and everything, but this one right here is a sample of that's lipemic. They can get worse than this. Sometimes you can see them, I don't know why it's like ICU, when you draw a blood sample sometimes, and you can see chunks in people's blood before it's even been spun down. It's pretty gross. This is somebody that probably just ate.
Oh, high lipid levels.
High lipids, yes. And, you know, these could be chylomicrons, or they could be just high triglycerides. This is a lipemic sample, and just so you know what it looks like, it can look just like cream. You think about that going on through your body, it's gross. So what I'm gonna do is I'm gonna just pass around, you can see an EDTA tube, and I'll pass around a normal, a lipemic, and if you would imagine this to be bright red, okay, bright red, the liquid part would be a hemolyzed sample. And I didn't have one to show you, but that's when the red cells break apart. So I'll just pass those around. So those all cause problems, and so do some of the drugs that patients can take. Now, the CBCs are very automated. You just plunk it on an instrument for the most part. But what happens is our tech has to be able to run that instrument and has to review the results, make sure that they're reading correctly, and look for flags that would mean that they have to manually process it. This right here is the instrument that we run our CBCs on that does the complete blood counts. We're going to see what's part of it. So a CBC is also known as a hemogram. You can, sometimes they'll call it a hemogram, sometimes they call it complete blood counts. You can have the test called an automated blood count, where we would not only do part of this, but those are the different orders that you can see. And so what do you get? You get the numbers of white blood cells, or WBCs. You get the numbers of your red cells. You get the hemoglobin content, the hematocrit. What's the hematocrit? Anybody remember? The packed red cell volume, yeah. So it's to do the red cells. And then these right here, we call them, in general, they're indices, okay? Just in general, anybody know what they would be for? Or have you?
The size of the carrying capacity of the hemoglobin.
Yeah, so in general, what they're used for is, this one will be used more for a lot for troubleshooting as well, but they're used to differentiate and diagnose different forms of anemias. And the physicians will use them for anemia categories and everything. And then we have our platelet counts, and their volume. So this is all part of the regular CBC. So it gives you all those things, but then it does something called a WBC differential. And I always have to smile when our NLT students come and And, for the first time, when we start talking about this, and, oops, and we tell them, guess what? You're gonna have to count 100 cells, WBCs.
Just a question about this one with the troponin.
Yeah.
So just looking at this, does this confirm an MI, or do you have to do something further with it, or?
The troponin would be the test that would be run to determine whether or not you had an MI.
So,
This is just the sample that you would put on the instrument.
oh, okay, so this was some blood that was drawn, and now it's.
Ready to go on the instrument. So what
Why does
happened?
it have the layers?
Oh, okay, good
Yeah.
question, good question. See, I leave something out, and that's just why I need to ask questions. This sample right here, what happened is it was a whole blood sample, you know what blood looks like. And then this tube right here went into a centrifuge. Okay, so when we use the liquid part of the blood, which is a lot of our testing, for CBCs we don't, it's all mixed together. Okay, so we don't spin it down. For chemistry tests that we'll get to, we actually spin it down. And this layer that's in the middle is a gel. It's a separator. It allows the red cells to be separated from the liquid. And we'll talk about why that's important later on. Yeah. So 100 WBCs. How'd you like to do that? Any of you ever done a WBC differential? It's actually not hard at all, but so what we do is, the lab tech, what they're gonna do is they're gonna take that off the instrument, they're gonna say, oh, Jane Doe has got abnormal CBC, so what I'm gonna do is I'm gonna go ahead and put a drop of that on a glass slide, I'm gonna smear it out, and then I'm gonna let it dry, I'm gonna stain it, and then they're gonna put it under the microscope, and they're going to count and categorize all the different white cells. And while they're doing that, they're also going to look and see if there's any differences with the red cells. If they look normal, if they're kind of washed out, if they're kind of weird shapes. So this is what a diff is. So it's 100 cells. And one of the things that students don't even learn in school, you learn WBC is fight infection, when you're in high school. You don't learn the different types of white cells, which you guys have, I'm sure. But these are what we're categorizing them as. We're counting and putting them in those categories right there. So this is a normal, what a tech would see on your scope, okay? So this is, what are those cells right in the middle right there? Everybody know what type? Neutrophils are 6. Okay? Yeah. And the red cells, what was the other name for them? RBCs are erythrocytes, that's right. Okay, so the importance of the CBC is for routine screening. It's done all the time. It diagnoses anemias, leukemias, and a lot of other diseases. It is a tool to monitor whether or not you're fighting disease. If you've got an infection, you're going to look for your white count dropping to know that you're responding to treatment. So monitoring disease is a big thing for the CBC. Okay, coagulation, the next department. This is Galen. And this is a simple little instrument. We don't go to a lot of tests on it, but they're all clotting types of tests. And notice the color right here of the tubes. What are they? Blue. Yeah. We just had a discussion about this before we started about blue tops, okay? So these are the blue tops right here. So between the coag and the hematology, we do a lot of tests. run PTs on everybody, seems like. So PT is the prothrombin time, and the INR is associated with it. It's stands for International Normalized Ratio. Basically, a few years back, they wanted to be able to take one result from one lab and correlate it, and they could match what another person's lab was putting out, which is a really good thing to do for treatment purposes. So if you're looking at somebody's PT results, it's the INR that we're focusing on, and that's what we call as critical. When it is critical, we call the INRs. So those are what the physicians are looking at. So somebody that's on Coumadin therapy is getting lots of these, and we get to know them really well coming into the, as you can imagine, into the lab. So pre-surgery screenings, they can be used for. And then we have our PTT, and I mentioned that before, our partial thromboplastin time. Also can be called an activated partial thromboplastin time. So you can see that little A in front of it. It's the same thing. So patients that are on heparin, it can be also ordered, with other types of clotting conditions, thromboembolisms, or DIC, or liver disease. They'll order that as well. Can be an evaluation for lupus, anticoagulant, or anticardiolipin antibodies as well. And there's sometimes uses pre-surgical screens just to evaluate, is somebody going to clot normally before I take them to surgery. So, this tube, and this is why we had this discussion right before this, is one of the most critical tubes in the lab. It has to be filled correctly. And it has a 9-to-1 ratio of the anticoagulant in it to, of the blood to the anticoagulant, I should say. So you can underfill these or overfill them. Usually it's underfilled is the problem. And they're not acceptable. We will reject them. It binds calcium, the sodium citrate that's in them, but they have to be filled correctly. Now, they are normally in your regular draw, we'll get to it later, pretty much the first tube that you would be filling would be this one, with some exceptions. So here they are. Now, also inverted 8 to 10 times, okay? Got it inverted. And then what happens with this sample, it gets centrifuged or spun at a high speed. And this has a special centrifuge, so you have to have platelet cord plasma actually. Can't go in any normal centrifuge. And when it's spun down, you're just checking the liquid. You can't tell if there's a clot there or not. Now, if we get weird results, sometimes we stick a stick in it and say, oh, they're clotted together. And sometimes that's part of our investigation and we'll find that. But we shouldn't have to do that if it's correctly. Going into the chemistry department, we have two kind of areas in our chemistry department. We call one general and one special. Not that special is any more special than general. It's just what we do. Because special is where the immunochemistry test is done. So we have two instruments. One's the general chemistry analyzer, one's the special. And larger hospitals can do a lot of more tests than we can do. We do over 50 at our hospital. So this is the beast, okay? I actually got to go out to California to train on this. It comes from veteran culture. And it has kind of two sides to it. One's a rapid testing side, into testing and into kind of this stuff. It's got electrodes on this side. And this side, if you think back to your chemistry, it's kind of colorimetric and spectrophotometric kind of testing. But most of the tests get done one test. So with all this cumbersome glassware and everything, and reagents and time, and this thing does it all. We don't do that anymore. We took away everything. And so what it does is it does lots of different patients all at the same time. Get there. Now for chemistry tests, I handed around the green top tube. For the most of these, what we do is we can use green tops and red tops. So green tops can look different ways. We have some like you saw there. This is one with a gel. You can see the gel at the bottom, okay? And I'll pass it around. So, you know, you put your blood in it, and remember the gel slid up? We have tiger tops. Tiger tops are red tops. They have a gel in them. We have red tops without gel. They're plain. And tiny little red tops without any gel, okay? What's interesting is these tubes that you think are nothing in them, red tops, is they actually have a clot activator in them. So they have kind of like a silica coating, okay? That allows the clot to form. So these are used in chemistry. And this one right here is just a heparinized tube right here with no gel. Okay, so these can all be used in chemistry. They can all go on that instrument I showed you, which is kind of cool when you think about it. So they're spun for 10 minutes, and then what they do is they use the liquid, which is going to be either plasma or serum. Remember the difference? Are you paying attention? If I spin this down, the green one, what's it going to be? Plasma. And spin the red one down. This has an additive in it. Oh, it doesn't matter. It's still, the liquid is the liquid, whether it's separated from the cells or not. And what about this one? Serum. So these are the tubes, and I added a couple more. And sometimes you might need sterile tubes or tubes of different yellow tops for certain tests. And certain tests we do in chemistry can be whole blood, and one of them is the hemoglobin A1C, which is for diabetes, yeah. So we do that, yeah, and we do it on the same analyzer. So that one we use a whole blood sample for. And in general, I mean, certain tests you could be sending out some of these tubes as well.
What do you do ammonia?
What do you talk? It is on ice.
Yeah, that's the nightmare one.
It's the new nightmare one, yes, because.
I've had mine sent back more than once.
Yeah, it's the new nightmare one because we found that it has to be spun right away.
Yeah.
Processed right away, or it's not valuable. We used to think that it was on ice. It's
It'd be all
stable.
set.
Yeah.
And when you work at a facility that used to have it couriered,
Then it's just, it doesn't work.
yeah.
Yeah. So, I mean, it's tightening up on that. You just, you're getting better and better, you know? It's just. So, chemistry tests. It's very important to know, and part of the reason why I'm just going through this plasma serum is so confusing. It depends on what you're drawing, what you're doing. If you're doing a PSA, what's PSA for? Prostate-specific antigen for to prevent prostate cancer, okay? It can only be done on serum, so you have to draw a red top. Can I make you feel better? You don't have to memorize any of this stuff. Isn't it nice? Because we make it so easy for you. If you're ordering stuff in our system and you go to the help screen that we've established right there, it tells you what to draw.
It also puts that in their label, that it has to be free.
Not in some facilities will do that. Yeah, ours doesn't, we don't do it some places do it that way, you're right. So there's always help for you, always double check, triple check, because you don't want to stick the patient in, okay? That's no fun, you feel bad. But usually patients is a little bit about it, that's cool. We do other types of testing too. We test spinal fluid, we test pleural fluid, we test urines, urine drug screens. So we do other kinds of fluids as well in chemistry. So what's cool, and I just was trying to touch on this, is that big analyzer, that, it's huge, it's big, and it's huge. It's like, almost like a car, a little car. Anyways, it does testing on over 50 tests at the same time. So when you saw that barcoded sample, there was a barcode on one of the samples that went around, okay? So you put a sample with a barcode on it, and maybe that barcode is a panel that's going to have, 10 tests on it, and then the next patient right behind it is going to have 12 tests done on it. Maybe this one's only going to have 1 test on it, but they're all on the racks running on that instrument at the same time. It's going to figure out what gets done. It's going to pipette them and add the reagents and everything and keep everybody straight. And all barcoded, computerized, very computerized. So it's done in 15 minutes, forever, what had to be batched years ago. So we do 360,000 chemistry tests a year in our little lab in North Unit. So, how's one sample not mixed up with the other is the barcode, okay? And that barcode tells the instrument the number of tests. So the main hospital computer is interfacing with the computer that's on the analyzer, okay? They have to interface, they have to communicate. Sometimes we have issues with that. But it allows that sample to coordinate everything. That computer and instrument coordinate everything. So in chemistry, what are some of the tests that you can order? And part of the confusing thing for as a nurse trying to learn the lab lingo is like, what the heck are all these tests and panels and profiles and what's in it? You gotta keep it straight. Well, our most common one is our complete metabolic panel, but it has everything in it. It's a real good general screening test. You can see all the different things that are in it, okay? So it has a lot of different stuff in it. The electrolytes are in there. And the BMP is going to be the electrolytes, and then glucose, BUN, and creatinine. This is the most basic one that could be ordered right here. For somebody, let's say, that's older, you just want to check out their electrolytes, you would probably order a BMP. Hepatic function panel would just be your liver enzymes, your liver tests, total introrectally, that's what the TNP is. And then we have just an electrolytes panel, sodium, potassium, chloride, and CO2. So those are panels, and they allow that physician to just pick a panel specific for what they want, but they can order and save money for their patient, the specific one they're interested in. Let's say, I just want a magnesium. You can order just a magnesium, or I just want potassium on the patient. So, and we have blood gases or ABGs, and they are run separately. Have you guys gone through drawing ABGs and everything, and looked at that as part of your training? Have you?
They do that as adults for anymore. They haven't had that yet.
Okay. Basically, an arterial blood gas, the most common area that you're going to draw is in your wrist, and you have a heparinized syringe specific for that, okay, type of draw. And what we're doing is we're looking at the amount of O2 and CO2 in general in their blood and determining whether or not they have an acid-base imbalance. Whether it's respiratory metabolic. And if you haven't, go back to that, if you haven't gone into acid-base imbalances, or if you're not comfortable with that, that's quite an area, you know, and to be able to tell that where your patient is. The sample has to be collected, especially brought to the lab right away. We do it a little unique in our hospital. The hospital that I trained in, and I worked I even worked in a blood gas lab off in an open heart suite in Illinois for a while. It was part of our rotation in chemistry. And we had a big analyzer. Here at Cary Medical Center, we have one of these, okay? Now, Fulton Hospital doesn't have this system, and I don't think Northern Maine has this system.
I'm not sure.
And I found it kind of interesting when I went to Cary Medical Center, because this right here is called an ISTAT, and it's what our respiratory therapists carry. In fact, what you're going to find out is anytime there's a testing kind of methodology, like your glucose meters or whatever, who's in charge of maintaining that program, making sure that the quality is done, and everything is the lab, okay? Because that's our area, we're good at it, okay? Same way for respiratory, we're in charge of these meters. These are point-of-care testing devices. And what's unique about them is this instrument right here is just handheld, this long. It's just a reader, basically. What's unique about it, and this doesn't show it, but you can see these cartridges right here. You open them up, you put your sample in it, and the cartridge is actually the real analyzer. So it's a kind of a unique device, but that's all we have. So, in some places you'll actually put AEGs on ice. These don't, they come right directly to us, they don't go on ice. So it's a little bit different. So check your facility when you go to, if you're drawing AEGs, exactly what has to be done. Special chemistry. Remember I said we had general and special? Special is really small amounts. Can you imagine? Nanograms. Very, very tiny amounts. You know, your hormones and stuff like that are what we're testing for in here. We use antigen-antibody reactions. They're very expensive tests. So this analyzer is our thyroid tests. Some of our iron testing right here, ferritin, B12, and folate for anemia testing. Our troponin testing is done on this analyzer, and CKMB, PSA, beta HCG, and Bella testing on what we do in Cary. And that's this analyzer right here. Okay. We're getting there. I think what we'll do is take a little break for 15 minutes. Sound good? Just because it's hot. And we're going to finish up the other departments and go into kind of the interactions a little bit more. 15 minutes, guys?
Don't forget to sign.
I'm going to take a look at microbiology and how it relates to what you're doing. First of all, micro is I just plates samples. I put them on the plates, and I don't work in microbiology. In our hospital, most of the techs don't work in this department. They're kind of a select few, just because of the intense nature of what they're doing, and to make sure that everything is moving according to the procedure. It's quite a specialized body of knowledge, and I think you can appreciate that because you probably evolved into micro, right? Anybody love micro?
Mary.
Mary does. I'm really surprised at that. Okay. I have to tell you, we'll get little things on why I actually like micro. Here's Nancy again, and I told you what she was doing. This is their main processing bench right here, so I'm not going to go into that anymore. Right here, and I meant to bring some today. Have you guys seen blood culture bottles? No. draw the blood, we put them in these specialized bottles, and it's quite a process to do it right, and we'll talk about that in a little bit here. But they go in this instrument right here, and this rotates up and down, we close the doors, and it's rotating, keeping it all nice and cozy temperature. And it alarms if one starts to grow anything. As you know, bacteria in the blood is really scary. Something we want to take the sample right, which is really crucial, and then treat the patient if they've got a septicemia that we have to work up and treat them for. This right here is our hood. And one of the things when I started out as a lab tech and training, I was in this big, our micro was like the size of this room here. I'm in the microbiology department in the hospital that I was trained in Illinois. And we had this long bench as you came into the room, picking two of these tables put together. And all the nurses from the floor would just kind of bring the big buckets. You see the big buckets that put placentas in, right? Those great big ones? We used to bring great big buckets of poop. And those sometimes, yeah. So obviously not completely full all the time, but I mean really, and other things, but just plunk them right there. And what we would do is we would lift the lid really carefully, take out our sample, plate it on the plates as fast as we could, holding our breath all the while. And it's just like,
Were you doing ovum and parasite? What were you checking for?
just stool cultures and everything. We plate everything on our plates, not just stools, but any type of sample. Sputums, you name it, on this bench, right out in the open air, in this lab. Of course, that's a long time ago. Now what we do at Cleary is, and that was a different hospital. We put everything underneath this tiny little hood, and you don't smell a thing. So, we get people like you, how you're gonna be, who collected a stool sample from Mr. and Mrs. whoever, brought it to the lab and think, oh, I'm so glad that you guys have to deal with it, and I don't have to. We get that all the time, and we just smile because you know what? We take it under our little hood, and we don't smell a thing. But you, on the other hand,
Smell it all.
smell it all. So it's one of the advantages of being a lab tech versus a nurse. I just have to kind of share that with you. Microbiology samples, some of them, and we've tried to make it as easy as we can for nurses. It's getting more and more complex. So Karen, our lead tech in microbiology at Cary is, and I'm sure other hospitals as well, she's put together some really specialized kits, depending on the sample that you want to collect, with the instructions in it, and the swabs that you need, everything that you need to collect it. They're very specialized, and they have the special viral media. So, make sure that you read through the instructions, you have the right kit for what you're collecting. And a word to the wise too, if it's something you're collecting and it's got like saline or something you're putting it into, make sure it's there. Things can dry up or whatever, make sure the expiration is good before you even collect your sample. For safety's sake, things that are highly infectious, please be careful as you process them, as you collect them, and I'm sure your nursing instructors have gone over that with you quite well. But we have anything like C. diff and influenza swabs and all that stuff has to be transported to the lab in a plastic bag, okay? Just to keep everything contained and protect everybody. Now, one of the big things about this department is you have to get it there in the right amount of time. And our gel transport swabs are really nice, but they're good up to 72 hours. And that seems like a long time. But they, most things get collected in a culture rat that has gel in it, so you can maintain the anaerobic as well as the aerobic bacteria that are there. If you collect a sample, get it to the lab right away. Don't let it sit and let things grow, because we don't want contaminants to grow. And, you know, in our rapid testing world, this is stuff that our microtech wanted you to know, by the way, is that things are not rapid in this department. And you're going to get pressure from the docs saying, where is, got the results back on this patient? You know, where is it? Can you check on that? And you can just kind of make them feel good too, because we have to look at the organisms at certain defined periods and do a workup at that time. Some things can take up to 7 days. It can take a long time to grow things. If you like to grow things, you know, plants take a long time, so do microorganisms. So be patient in the lab with your results coming in this area. We can give you preliminary sometimes. So, you know, if the dog wants a preliminary, you call the lab, talk to microbiology, say, hey, have you got anything growing yet? We really need to know, you know, what's it look like? Is it gram positive or gram negative? And that can give the doc a lot of information as far as treatment. Now, something you might not realize, and it's kind of a cool area, and maybe you guys are so smart, you know all this anyways, is that you can't use any antibiotic on a patient. The medical staff, the pharmacy and the lab take the data, they take what our patients are growing and what's out there and what's working, and they decide what antibiotics you can use. So it's only those antibiotics that have been allowed that are going to be tested, sorry. And you might have some salespeople come and say, oh, you need to use this one, and they're not going to be on the panel, and you can't test your patients and see if they're susceptible. Did you guys know that? It's only what they allow on the panel. Very controlled. You know, and why is that? You guys know why? Why wouldn't we let docs use any antibiotic they want in some patients?
Some are only receptive to certain antibiotics, and don't work for those.
That's right.
Your resistance to your system.
That's the thing too, is the resistance. We don't want things to become resistant. We want to be able to treat them for the patients, and so we just don't allow anything to be used, okay? So that's set, and eventually it will be looked at again, and then more can be added, but that's the safest method for the patients. Blood bank, that's my baby. And this is old data. I didn't update this because I've done this before. But in 2009, we gave out over 590 units of blood. And I'm just going to go back and look because we've been really conserving, and we have really cut that down big time. And I ought to go look at the numbers of units that we've been giving out. Our criteria has changed. We've tightened up. We've really been educating the physicians on when to give blood, because in our hemoglobin is the basis for that. We use that as our basis for whether or not somebody gets a transfusion or not. But a lot of people can go and do better without a transfusion. Okay? Transfusions, believe it or not, are not good, because they can affect your immune system for the rest of your life, make you more susceptible to disease and make you die sooner. Did you guys know that? They're not necessarily great. So you don't want to give somebody blood. Getting blood when you need it can save your life. But if you can get by without needing it, you want to do that. And so you want to only transfuse when you need to transfuse.
Are they educated to use like fluids more or expand standards, relevant standards more?
I don't know about those as much, but of course we have the cell saviors in OLA. You know, and certain surgeries and stuff, we're using that. And certain, you know. Very few surgeries take blood. It's the osteopathic doctors, the knees, the hips. And that's pretty much it, you know, for the general surgeries that you do that use most of the blood. You might we'll go through the orders and stuff. We have a lot of patients that come through Cary that are chemo patients, you know, that are getting blood, and their criteria is different. In fact, I wish we could just say, oh, they have to have a 7 hemoglobin and you can't give them blood, but that's not that way for a chemo patient. Their protocol or whatever that's set by their oncologist might be a hemoglobin of 9 and intransfusible, because that's what's set.
Now, each time you transfuse somebody, they develop an antibody?
No.
Is it,
It's not every time.
who is it? Did you check for anyways,
I'll talk about antibodies, okay? This is our little blood bank right here. It's a little small little room right here. There's not much to a blood bank. In fact, we have our blood bank refrigerator where we store our units right here on shelves. We sort them according to the type. If you're looking at them right here, so they're sorted according to the type. Here's our O's up here, here's our A's, and A, B, and D. Anyways, right here, these little yellow stickers, and you might not realize that, our blood, when it comes to us, we go ahead and retype it. We don't just rely, they come all, you know, like you get something from the store, here's the A blood, here's the B blood, but we don't take it at how it's labeled. Just in case there's a mistake or whatever, we type it again.
How long do you keep that stored for? Does it have a
It has
shelf
an
life?
it has an expiration. Every unit has an expiration, and we monitor that very carefully. In fact, yeah, it's a little over that. They're all different depending on how the supply is coming to us and everything. But we look at that expiration, we monitor it very carefully. We're in overstock at Cary, and because if you heard the news a little while back, last November I think it was, Eastern May decided we're not going to get blood from the Red Cross anymore. Anybody know where their blood comes from?
is it covered in Massachusetts or?
Washington State.
Okay.
Does
Well,
that
United
blow
States,
your
that makes
mind?
sense.
Or far away?
So
That's not mine.
Tamik is part of the Eastern Maine system. So Eastern Maine and Eastern Maine's associated hospitals get blood all the way from Washington State coming to Maine. Isn't that amazing?
What political reason did
Yeah.
that happen, I'd like to
It
know?
was cheaper.
Yeah, exactly.
It was a cheapness, and it was also, they actually were saying that there was a little pressure, and I'm not so sure. Pressure, yeah. So I'm kind of waiting on that. But it changed the whole, you talk about political, it changed the whole blood thing for New England.
You can't even get fresh fruit here fast enough before it perishes. How do you
Yeah,
get blood?
but really, it changed the whole blood picture for New England, because then we had to scramble. Because when we needed something, we went to Eastern Maine. You know, it's like, hey, we need blood on this person, platelets, you know, can we send them up, drive them up? We'll get them. Now, if we are an overstock, so we get a little extra blood, and St. Joseph's now is our new Eastern Maine. And so we call them up if we need something that, they have something we don't have, we'll get it from them. Or all the blood that's for all of this area comes from Dedham, Massachusetts. So your blood drive right here is tomorrow.
Yeah.
If you give a unit of blood, it will be taken trucked right down to Dedham, Massachusetts. They'll do all the testing, and then it will come back up, maybe here, maybe, you know, all the hospitals in New England.
Now, Lisa, what about Tamik, since they're associated with Eastern Maine?
It is coming from Washington
Okay, so
State.
they get their supply.
Yeah,
Oh,
they're a separate source.
Interesting.
Very interesting, very political.
Wow.
But, you know, it's, the patients so far are all good and they get good quality either way, so. Now, in the blood bank, there are two different orders that are the main ones for people getting blood. One is called a type and screen and one is called a cross match. Have you guys studied this at all? You know the differences between the two of them?
No, we haven't.
Okay, some people, they call them type and cross, some people call them different things. It depends on your hospital or whatever. And physicians will come in and they'll confuse the heck out of you because their hospital, they use a different lingo. But anyways, type and screen, the whole purpose of this order is right here. Before surgery, it lets us know if they have antibodies that are going to prevent safe blood transfusion. And when they're going to go into surgery, with this, or maybe coming into the ER and you think, oh, they might need blood, we're going to apply a blood banking bracelet to them, okay? So we'll go over that in a little bit. The next order is the cross match. You know somebody's gonna get blood, this is the order that gets you the blood, okay? So in this one, we do all the stuff that we did up here, okay? It's not like we skip any steps. We're going to check the blood type of the patient, same as this one, and we're going to screen them for antibodies. But also what we do, and what a cross match is we're going to take the cells of the donor, remember those blood bank, those bags of blood, we're going to combine them with the plasma of the recipient, I'm just put blood here, but plasma, the liquid part that has the antibodies in it, the person that's going to get it, that's going to be combined with those red cells, and we're going to see if they're compatible. You know what blood does when it's not compatible? It clumps. Basically, we're the clumping people. You know, that's what we do. We look for clumping or agglutination is the correct term for it. So there are different types. There's automated ways to do blood bank. At Carey, we do things very manually. Here at Northern Maine, they do things manually as well. Small hospitals, it doesn't pay to have automated systems for blood bank, but they are out there. Other tests that we can do, if you have prenatal patients, we'll do group RH and antibody screens. And let me go through here. And if they had an antibody, by the way, we had a couple of people that had different antibodies just recently, and we do titers of them. So basically, we see how much of the antibody they have, and see if it's changing, you know, is it going up, and that lets us know if there's any fetal distress at all. So in time, amniocentesis, or early delivery, C-section or something,
With pregnancy development work,
no.
why
Okay.
did they ask how many pregnancies then?
Okay, so let's talk about antibodies. You can have an antibody, and just because, well, first of all, how do you get an antibody? Because you're exposed. You can be exposed, you can get a blood transfusion. Okay, say some of you in here, maybe you've had a blood transfusion before. You could have an antibody because you're putting somebody's foreign tissue into your system. And your body's going to react to it, maybe, but not necessarily. A lot of times it doesn't happen. If you've had a baby, that baby is foreign, their blood's foreign, and their blood is going to mix with your blood a little bit, you know, in the process of the birth, in the process of a miscarriage, any time like that. We call it a fetal-maternal bleed or fetal-maternal hemorrhage. So the baby's blood mixing with mom's blood, the mom can react, okay? So those are the main reasons, and there's some other things there that can be natural antibodies. But for the most part, you've either had a transfusion or you've had a pregnancy, and you could have antibodies. But you don't get them every time. Now, we have people in our blood bank, we can blood unit after unit after unit, and they never, ever have antibodies.
Why do they not ask you just if you've been pregnant, instead of saying any pregnancies? What is the reasoning for that? Because we always had to ask how many pregnancies, not how you were pregnant.
Well, as far as the blood bank, if we're really evaluating something, is we're gonna wanna know is how many there were, was one successful and the next one not, is an indication maybe there was problems, miscarriages, looking at the whole picture. If there was an issue. We look at the whole thing. So, now, one of the big things, and the big antibodies, and it's an amazing thing, is that we prevented problems with lungs because of Rogan. We do antibody screens right before we give Rogan to an Rh negative mom. You guys are all familiar with Rogan, or okay? Do you know when it's administered? Within 72 hours after delivery. Yeah, you guys are good. I thought you might know that. So I just thought I'd quiz you. Your teachers have done a good job. So you might not know the whole process, what we do in the blood bank, okay? One of the things is once the baby's delivered, we'll draw the mother's blood, fairly soon after delivery, for an Rh negative mom. And what we'll do is we'll do what's called a fetal bleed screening test. Did you guys learn about this? Haven't heard about it. Okay, well, it's something we do. Basically, it's also called the Rosetting test. You might hear it called that. And what we do is we want to see if it's negative or positive. If it's negative, it means that bleed is sufficient that that mother encountered by delivering this baby, so that one dose of Rogan will cover that bleed. It's less than the 30 ml bleed. It's enough to have one bottle of Rogan. And if it's positive, we can't say how much of a bleed there is. We have to go ahead and send it out because we don't even allow other people to do. But Easter Maid does these, and they will do ours. They do something called a Cry-Howard-Bedke test. Anybody ever heard of that? Basically, fetal cells and mum cells, red cells, they all act differently. The hemoglobin is different in a baby cell. So you can treat that sample of blood with acid and leach the hemoglobin out of the mom cells. And so the baby cells, they're more resistant and they stand out and they can be counted. So you can quantify the bleed and tell how many vials will cover the bleed. In blood bank, it's very simple. We use this little set of reagents. It's updated since then because I think this was older. Yeah, it's expired. They better not be. Well, they're expired now, yeah. Well, yeah, they're all expired. No, we're not using these ones. Anyways, they're antibodies. And some of them are actual red cells with suspensions. So we're doing antigen antibody tests. And I won't go into blood typing and all that stuff there. Hopefully you've done that at some point, typed. We do tube testing, and these are just solutions right here at this point. And we also use something called a gel system. Now this is fairly new in the most, recent last few years that it's been around up here. Basically, this is a really sensitive way to tell if somebody has antibodies or not. This is quality control for this round here, it's not patients. But what happens is we do all our cross matches and all our antibody screens in this. We put, let's say this is a cross match. We're going to put the cells of the unit. How do we get cells off a unit anyways, do you know?
Don't you have those little tube sections that you
Yes.
can snip off?
They have little segments on the
Yeah.
top of a blood bank unit. It's kind of like I used to say, the base of the coelomel. You guys remember coelomel systems? You guys are too young. Anyways, they're little segments that are divided, so you can just pull them off and you can do your testing and not enter the unit. make it contaminated, which you wouldn't want. But anyways, we take the red cells, and then what we do is we put the patient's serum on top of it, or plasma, you can use either one, and then what we do is we incubate it, and then we spin it down. Now this is a positive reaction, and this is a negative reaction. This is a gel, and so it allows us to distinguish. Sometimes reactions will show throughout it. We have a grading system. But if it clumps, it can't fit through the gel, so it's straight on top. And if it doesn't clump, it goes through the gel to the bottom, and that's your negative. Kind of simple. Here is a blood banking bracelet, and you will be comparing these at least, maybe applying them as well. They have a segment right here where you write the patient's identifiers. Now, blood banking is more critical than any other kind of sample identification. You've got to have their first and last name. You have to have, we use the medical record number, okay, in blood banking, because that is a number they have for life. Medical record number. Not the number that they get every time they come into the hospital, which is their hospital number. You have to have the initials and the date and time of draw from the phlebotomist as well. Okay, so we need to have two identifiers on this, and the information about the draw time. Now this little label right here, you peel it right off, and you stick it to your tube. Okay, the bracelet goes on the patient, and then this pigtail back here is pulled off, and it comes to the lab in the blood bank. And so these stickers we use. But this number here is a unique number to that patient, and it will be attached to all the blood products that go to that patient. So we use this number as well to identify it, and it's it. Now, there are even more high-tech ways of handling blood bank out there, including locking systems. And I don't know if you've seen those or not. We don't have that system here. So we discussed that our blood bank products come from Dead Mass, and we use St. Joseph's. What we keep in our blood bank are leukocyte reduced. Everything is reduced. We don't have to worry about like febrile reactions to white cells. We keep fresh frozen plasma, and we order platelets when we need them. And the mistakes in blood bank, and this is, I know, until you have really kind of encountered it close, you may not realize how fatal this can be. Okay, every year there are people that die from transfusion mistakes, what you said. So record keeping is really huge, and when you take control of a blood product, we expect you to be just as important to the system. The system in your hospital is designed to keep that patient safe, okay? And if you go outside that system, you could be exposing your patient to harm. So what's the process to get blood? First of all, the patient's identified very carefully, and the blood sample is drawn, and that bracelet is stuck right to the tube. Bracelet, tube, that's what we test with. The blood bank's going to make sure that it's correctly labeled and spin it down and compare it with blood bank records. Some hospitals will have it all computerized, some will have a card sample, card file, but we keep all records of any blood product that person's got in any kind of blood bank testing. We keep it forever. We're required to. And then what they're going to do is that after they've typed them and everything, and they're going to give them blood, they're going to go ahead and select the type that is compatible. Okay, not necessarily the same type. What we try to do is give the same type. But if you don't have it, or if you've got another unit that's going to expire and you don't want to waste because blood is precious, you're going to be compatible. You're going to check before you do, depending on on your process and stuff, you're gonna check the plasma of the patient for antibodies before you transfuse them. And then you're going to do this compatibility. Now, it takes an hour. What would you do if somebody's bleeding out in the ER?
Oh.
If somebody's bleeding out, comes in your ER, and they just had a car accident, the physician who's there can request and sign off to get uncross-matched. You bypass this because you're just bleeding it out, and we gotta save their life, we would give them O negative. Okay? If they're O negative, then, they don't have, those cells don't have any A or B antigens on their surfaces, so if somebody won't react, it's a universal.
What's the difference between O negative or O positive, would it matter? Because I thought that O period was universal for not O positive or O negative.
Anybody can get an O positive unit once. And hospitals all have things in place to allow, used to be years ago, give them O negative, okay? But for an older person that's not going to have kids, or, they're not a child, you can give O positive. And sometimes that will happen depending on your hospital. In our hospital, we have a policy where if we want to protect that O negative, okay? We want to protect it for the RH negative moms, and we want to protect the children and everything like that. Save it, because it's hard to get, it's really hard to get. And so we would have our pathologist approve if we wanted to give O positive to an O negative. Very rarely has it happened, but sometimes it has. But you have to watch it, because you may be creating an anti-D antibody in the person that you're giving it to. So they could get 6 units, all bam, 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 one right after the other. But the next time they, let's say, 3 weeks down the road, they need a blood transfusion, they could have an antibody that you created. And D is very immunogenic and very likely to cause
Is that what's called the seroconversion? It's compatible but not exact. Can you cause is that a conversion of antibodies, a serum conversion to an
Not
antibody?
really, you start producing it.
Okay.
If you stimulate somebody's immune system, not everybody will
Okay.
react. I think you're thinking more in terms of like if you were getting a viral illness, you sort of convert. So after the blood's tested, it gets labeled. And then what we do, so we have to put a tag on that unit with the patient's name, their blood banking bracelet, we have to have their medical record number, we have to have all that information. And what we have to do is we do a transfusion slip that goes with the blood, and then we have a process in place in our lab, because just writing things down, you have a chance of getting an error. And we have somebody check it over and do all the paperwork. And then the nursing unit is notified that the blood's ready. And what happens, let's say you're the nurse coming in to pick up the unit of blood. What you're going to do is you're going to verify that blood unit with the tech in the blood bank. Make sure everything matches. And then you're going to take it out to the floor to give to your patient. You're going to take the vitals, as I'm sure you've gone through, right away. Within that first 15 minutes is the time frame. If there was going to be a reaction, it would happen at a real, ABO incompatibility type of stuff is going to happen right away. Serious transfusion reactions are going to happen within the first 15 minutes, but then you're going to take it and you're going to watch for signs of reaction. You have to record all the vitals, and if you haven't had a chance to see this, make sure you look at this process. 2 and the amount of blood given is recorded. And then what happens is after that person's transfused, the paperwork, the transfusion paperwork comes back to the lab. And it's our responsibility to check it over, make sure that everything's carefully recorded, nothing's missed, okay? And all the criteria are met. So in this whole process, we're players right together. But when it comes to an inspection and oversight, a lot of is our baby, you know, kind of like transfusion medicine is our baby. So, you know, they weigh more heavily on us. Okay, so also when you come to pick up a unit, we take 2 segments off the unit, and you write that stuff. It's kind of got out of order, isn't it? But anyways, this is the process for signing it out right here. Signing it out in a logbook and reading it back and forth to the nurse. Urinalysis. We finally got out of blood bank. Did I spend too much time on blood bank? Here's your analysis, and you probably have even a little familiar with that. You might go to a doctor's office and, you know, they have one of these little vials. Inside it are little strips. Each pad is a different chemical test. You dip that in your urine, and then you wait and time it against and match it to the colors here, right? You've all done that before? Pretty basic. We have a reader that does all the reading for us. So we dip it, blot it, and put it in the reader, and it spits out the answers, okay? And we have criteria where if it's meets the criteria, then we'll look at it under the scope. So this is what a dipstick includes. So we also look at color and clarity. Right here, if protein's positive, we have a little tube test called an SSA test, where we check to make sure that it's a true protein. Then if it has positive leukocytes, blood, protein, or nitrite, what we do is we spin it in a centrifuge. And you might think this is kind of ick, but we pour off that urine and we look at urine sediment. So there's a lot you can see in the sediment. You might not have realized we did. Did you guys know that? Did we look at urine sediment? Some of you know, and some of you yes. Okay. So this is some of the stuff that we can see in a urine sediment. Yeah, and some of it you can tell just looking at it. You collect a sample, but some of it you'd be amazed. You can't tell there's blood there until you actually spin it down or dip it. Samples everything in your analysis. Clean catch is the preferred for culture and sensitivity, and you guys are going to have to instruct people on how to clean and do a clean catch. Have you guys done that at all? Okay, you're experts, good. We have a rejection built in. What we do is if they have too many epithelial cells, we use that as our basis that they're quote unquote dirty sample. You know, they didn't collect it right. Because that's going to tell us that there's a lot of surface bacteria that are there as well. They can affect the results, and we're not going to get good results. It can mask a pathogen, so we put a comment in there. And if it's greater than 10, squamous epithelial for high-powered field, then we'll go ahead and not culture it, even though they ask for a culture. It would have to be collected. If you have a sample, it's going to be refrigerated immediately because it's going to be processed right away. Random specimens. Sometimes, like somebody coming into an office, ER or whatever, it's really dilute. So it's not going to give us a good picture of their health. The best specimen is the first morning because it's concentrated. You can have timed urine specimens. Have you gone over time? How to collect a timed urine collection? Yes. 24-hour urine samples? Okay. If you mess it up, then start over. Yeah. If you mess it up and if you don't start over, then you are really going to affect your treatment So, it's very important, and it's important that you don't let it sit out at a nursing station, that you put it in the refrigerator while you're collecting that, that's important. Histology, here's Diane, she's putting something, some formalin, on a sample. By the way, we've changed it since then, because you're not allowed to have this above shoulder height. This is old. We've been more safe since then. Histology, they really want to discuss labeling is everything. So, in a histology sample, you guys know what I mean by histology sample. You know, you got 100 tissue coming from your doctor's office or from the station that you're on, or from the OR. You've got to have 2 identifiers. That's key. The time. Because if you don't have that time, the pathologists, when they're looking at that, they use that time to know if it's abnormal or not. They're looking at cell changes, and cell changes start occurring once you start taking that sample. So time is important. The diagnosis of the patient. If it wasn't up there or not, but obviously, you know, left or right, sample where it is, what the body part is important. It's important in micro too. The body part, you know, if it's a cyst of an eye, where it is, you need to know. We look them up differently. Histology, frozen sections need to be scheduled. You guys know what a frozen section is? Basically, it's a different procedure, a rapid testing procedure in histology for OR procedures where they're going to remove a tumor, for example, a breast tumor. And bone marrow biopsies have to be scheduled as well. They're done by the pathologist in the histology department. Now, that's something to wake you up. By the way, these are our 2 new pathologists relatively. This is Dr. Porter and Dr. Sharma. And Dr. Porter is also working with Northern Maine as well as with our hospital. And Dr. Sharma is considered our head pathologist and the head of our blood bank. Right now, what we have, this is our histology department, and over here where you can't see it, there's a little window to the OR. So any sample that came from surgery comes plunked into a little bucket, put in our window, and they're grossing it. So they're looking at a tissue right here. What is that? That's my question to you. You guys are nursing students. You're supposed to know your tissues. Well, yeah, definitely fatty, isn't it? Something that's fatty. What do you think it is? Bad answer. You guys didn't get it. Anybody want to make a second guess? It's breast tissue. It's a breast. Nobody can guess the breast. Huge. And you guys, I know you know what they look like, but
Is that normal breast tissue or not?
I really don't know the background of this, but yes, well, really didn't look like that. A lot of fat and everything, yeah. It's amazing, and it's, yeah. So.
It's just one.
I think it's just one. Yeah, I know.
Is that a reduction or were they just?
No, we don't do reductions. So I'm assuming that person, that looks like a mastectomy, right? Because of the amount in there, but they take out a lot of breast tissue when they take out this whole mastectomy. You'd be amazed. Yeah.
I think people are deceived when they go for like mirror
I think it's just a little bit, it's a huge amount.
It's very painful for them.
Yeah, it's a huge amount. So, sample collection. So we use blood, urine, feces, tissues, swabs and scrapings, you name it, hair, nails, All kinds of samples come into the lab. Blood's the primary sample, so it's important to go over how we collect. And you're going to be collecting blood as a nurse, most likely, or drawing it off an IV site, like this. It's okay to rob off the internet, right? I thought that was funny. I brought up some drawing devices up here, and similar to these, okay, because there's all kinds of different things you can use to draw blood, okay? If you're drawing off an IV site, then you're just going to use a syringe, okay, and everything. If you have an established line, you're going to have to waste. And then, so you're going to have two syringes. But we have devices where we have holders and the needles go in them, and I brought examples right here. We have butterflies. We have many different things that are designed to be, these are for vacutainer draws. So they're designed to, draw, put in their vein and fill, when the vacuum is filled in the tube, you draw the correct amount. All of our draw stuff right now, and I'm so thankful, is safety. Because you don't know what it was like 2 years ago, well, of course, you still have stuff in nursing that is not safety devices, which just blows my mind, that there's some of that stuff around. There is an order of draw, and mainly, we call it a rainbow. Our simple test, we're just doing a blue, then a red, and a green, and a purple. Okay, those are our basic tubes. In other words, as a nurse, you really need to know this. Okay, there are cards out there, cheat sheets, you name it, if you need that. These are blood culture bottles right here. Okay, so if you're doing a blood culture, you want to draw them first. And the site has to be specially prepared. And I didn't go over that, but that's very important. Yeah, anything that is sterile too, and everything, those tubes also have to be drawn. And then you start with your coag and go from there. So the basic collection, and we call it the rainbow, blue, red, green, and purple. And we had a discussion as far as before we started here today. The blue is, if you're using a butterfly for some reason, you're going to not draw it and fill it enough. And so it could be rejected, it could get erroneous results. So you have to have a waste tube to fill that dead air space in a butterfly, all the tubing, and I got butterfly up here if you wanted to see it. And different hospitals will have different things, and we had a discussion. Ultimate ideal would be to draw two blues, just to get it primed and then use the blue, so you wouldn't be introducing anything else into it. The other thing that you could use, the desired thing, is to have a red tube with no additive at all. No thought activator at all. Could be done before blue.
Just to prime it or to get a
Just to
sample?
prime
Okay.
it. Just to prime it. You just have to remove that
Right.
dead space.
Couldn't use a syringe?
Well, this would be a vacutainer system, so it's already in their vein, and you're pushing those tubes on.
Okay.
If you had a syringe, then
I'm
it
thinking of a
doesn't matter.
butterfly.
If you have a syringe, or you have a transfer device, and you've already put it in a syringe, then you can just go directly into your blue,
Okay.
then your red, and your green, and
Because
your
if you take
purple.
that, you keep, taking that out, you do that inside the tube you draw, but it's not transferred.
So never draw above an IV site or below an IV site. Well, why do you suppose is that?
Because it dilutes it.
It dilutes it, you get erroneous results. Either you'll be measuring the IV fluid, and that happens, okay? It's a big thing. There are some rare exceptions where that's the only place that they've got. That's one vein, and they're so hard to draw, that's it. So if you turn the IV off for a while and allow the blood to circulate, then you can use that site if you have to. Make sure that your order blood draw is done. You want to fill your tubes immediately and to the correct level, and I said they're designed for the correct level of fill. Now, one of the things that people, when they start drawing blood on some of these purple tops, usually they've got a line like on them, and halfway is full, and that's where it stops. But, so if you push more blood in, you're overfilling it, and you could have a problem. You invert them, and if you draw from a line, you have to waste stem first. Unless it's an IV start, and you haven't hooked anything up. Blood cultures. You remember that picture I showed you of our incubator? They have to be clean with alcohol and betadine in circular pattern, and it's very specific for how we do that from the center out, because we want to make sure no skin bacteria get into our sample. And to let you know, we've had nurses draw blood cultures, and we had a really high contamination rate, so now it's just techs and a phlebotomist that are drawing it. So we go back and forth, and then we'll probably do it again, and let the nurses try it again. You know, you've got to be really careful. And we also cleanse the tops of this blood culture collection bottle tops before we put the blood in as well. For blood cultures, they get collected twice, times 2. So we get 2 sets of bottles, an aerobic and an anaerobic, and then another aerobic and anaerobic. So we can fill in 4 bottles. Samples have to be collected before the antibiotics are given. So that's a big deal. So you don't want to start giving somebody antibiotics and then, oops, the blood cultures weren't collected yet, because that gets in your system fairly quickly, and it could mean we don't pick up what we're supposed to pick up there and be able to do sensitivity on it. So it's a big deal. Labeling is crucial, and we have issues sometimes with this. If you draw a blood sample, you label the tube. You label it with the patient's name. You label it with a second identifier and a time and date and your initials, okay? If it comes in our lab and it's unlabeled, we reject it. We don't relabel. We'll just call you up and say, oh, you gotta come do it, or we throw it out. Now, it has to go on the sample container. So let's say it's a placenta bucket, and you just stick it on the outside of the bag that the placenta bucket's in. That's not acceptable. Or you just don't want to touch that because it's yucky. You put it on the outside of the bag, whatever it is, not acceptable. So this is all the stuff that's got to go on there I just mentioned. So sometimes we reject things. It wasn't enough. It was in the wrong tube, so you need to check that out before you draw a sample. Don't do it twice. They weren't fasting. The sample was hemolyzed or lipemic. For 24-hour samples, clotted samples in anticoagulated tubes, because of mixing and because it took a long time to get the blood or blood gas samples improperly labeled. So, here's a requisition right here. Here's a blood tube. What's the problem?
There, 48, 49.
Yeah, okay, that's
And John
one.
Barber and Joe.
Okay. So the last name's different.
And the middle number's different.
Okay.
It's the wrong one.
Yeah, so they're 2 different people, aren't they? That can happen. What do you think about this one? Same thing, requisition down here too. Tube's not labeled. Ooh, bad.
Should you allow them to come in and like, when we had unlabeled tubes, we rejected them. We didn't say, we think more unlabeled than that, we left their hands, so. But I know it's different in every hospital and policy, but we vary it and, so it could be anybody's
Yeah,
at this point.
it could be, you know, technically you should totally reject it. Some cases, you have to evaluate that. What kind of sample was that? Is that so hard to collect and it's the only one and it couldn't be anybody else's, you know, you may allow somebody to come over and label it. But he just dropped it off and, you know, it depends. It depends on the hospital policy. Yeah. Yeah, I mean, to be the safest, you would reject it. But in the real world,
I mean,
in
that's
the
far
real
more
world,
ago
the
than
real
it's so hard
world
to
is the
get,
real
but,
world,
yeah.
and, you know, you can do things differently sometimes. Okay, I was gonna bring you a hemolyzed one, I didn't, so you can't compare it, but basically a red plasma. So if it's hemolyzed, one of the big things is that potassium is an intracellular cation, and potassium is the one that's gonna just leach right out, and be 3 times higher. You have trauma from a poor draw, you're gonna have an electrolyte balance be thrown off, and particularly the potassium. It's a critical electrolyte, and that's a big thing, and we can't use it, okay? So, some things about the nurses in the lab. We're all working together for the benefit of the patient, you know. And we have to just, you know, think about where we're coming from, where you're coming from. And a lot of times things happen because of lack of communication. That's a big thing. You know, communicate. We'll communicate with you, you communicate with us. Timing is a big thing. You know, you need to go draw this drug sample on this patient at this time. That's important. You communicate it to us. Because timing is important. We need to communicate with you when, like, oh, we're too busy. We've got one phlebotomist and she's been down at the ER. We're going to be a few minutes before we can get to your patient on ACU. And therapeutic drugs testing, I'm sure you've kind of gone through that, troughs and peaks and everything. It's important that we get that straight. A lot of miscommunication happens in this area right here. So be aware of that and do your best to try to prevent it. We have to produce quality results, and we're not just putting numbers that are fed through a machine. So one of the things that will slow us down is we have to run quality control. We have samples that are outside patient samples that we run on, and we know what they're supposed to get. We have to run it periodically, and we have to do maintenance periodically, and we can't do patients at the same time as that. So if we say, oh, our instrument's down for maintenance, we're doing this, it's going to make the lab testing be right. So be patient with the lab if they're in that situation here. Staffing changes for the shifts, can we slow down as you know it? Slow down in nursing, slow down in the lab when you have less people on staff. Respecting each other is crucial, and one of the things that lab techs don't like, and sometimes nurses, you fall into it, we even fall into it ourselves, but for some people, they really hate this. Is, oh, here's the vampire again. You know, try to avoid it, and you'll be better friends with your lab. They don't like that. Anytime you have a question about a test or anything, ask us. And I went ahead and I passed these out to you, if you got one, otherwise you can come up and look at the drawing devices here. If you've got a question about a lab test, what's this lab used for and about it, just in general, you want to Google something, use lab tests online. It's on the back of that. That is the place to go, okay, for general information about lab tests. It is our responsibility to call you with a critical result. Critical results, I'm sure you handle, but we can't give them to a ward clerk. We can't give them to anybody but a nurse or the physician. So we're going to ask your name. We're going to tell you the result. We're going to say that, you know, so-and-so has a critical result, it's high, and would you repeat that back to me? Okay? So be patient, state it back, just to make sure you heard it right, and everything. Okay. Just going to finish up here with a couple actually happened. So this was a home care nurse. They have to draw a CBC and a CMP. So, and they have lots of people to draw and everything and do stuff with. So, he didn't get to it till the next day, which wasn't a big deal. Got him off to the lab, but they asked him to recollect. Anybody have an idea what happened here?
They bought it, the CBC probably bought it, right?
They could have. That wasn't the issue in this one.
That's newborn?
The key for this, and we actually had some problems with the electrolytes, and we couldn't figure out because the sample was not hemolyzed. The nurse said, I just drew it and brought it in, and lo and behold, and I can't remember if it was freezing temperatures or hot, but the tubes were not kept at room temperature. They were kept out in a car overnight, and so just to be, that's FYI, don't do it. Here's another thing. This actually happened, not locally. Any idea what happened? They got the wrong blood type. The blood bank did it right. They labeled everything, and this is a major hospital. This actual, and I simplified it, of course, here, but the hospital that I trained in, they did open heart surgeries, and they actually had the unit of blood come to the OR, and they had two at the same time. So the nurse wasn't doing their job to read that unit to the person that was receiving it to be administered to the patient. And so the patient died.
Is there nothing you can do? What do you do if you realize all of a sudden they're having like a reaction to the blood?
You stop the transfusion immediately. That's the first thing that you do, okay? You don't throw away anything. The bag goes back to the lab, and it has to be, everything's going to be evaluated. All your paperwork and all your stuff you have to look at. The lab has to do the same. Then we draw blood samples and urine samples, we compare them with the pre-samples, and we do a whole workup on the transfusion reaction, and the pathologist has to evaluate it. In this situation, if it was an OR and they got the wrong kind of thing, or if it's in-house, one of the things that they would do is they would, lots of fluids, keep their IVs lines open and lots of fluids. But it would happen right away. But yeah, scary, because a nurse did, and a transfusionist, they didn't read it. They would have noticed that, oh, this is the wrong patient. They weren't doing their job. So everything, can I just kind of put this out? These are real things that actually happen. Any questions? About the lab or whatever? Did I overwhelm you?
I wanted to address kids, special concerns with kids. Do you guys learn special techniques that make it easier? I know when they used to do blood draws for children on the child adolescent unit, the psychiatrist would usually order blood before around the area, so it would be less traumatic for them. I don't know, is there any protocol?
At Carrie, we don't do that so much. They could do that in the ER, but we're very patient. If you have a child with anything on, you're going to talk in language that they can understand and reassure them. You know, we tell them, we have the parent hold their hand. If they're a baby or a young child, you actually have to hold it physically
Right.
down, which I hate because, you know, you think about that being traumatic later on. I mean, it does traumatize kids. We give them stuffed animals, we give them stickers, you know, we try to make it as fast as possible and as painless as possible. We usually use butterflies.
I let them use a lot of the work too, I feel like, so having them sit there and say that on the time
question of, is there a time you can use a butterfly and you can't use a butterfly?
Butterflies are expensive. And, something, that's kind of happening right now is some of the manufacturers that kind of not having, them available because of just the high demand, everybody's switching to these. Yes, but they're very
The
expensive.
great key is on older people or people who are prudent because of their,
This is a butterfly right here, okay? So, yeah, they're nice because the only thing, they're the same, four size, they're the same needle. The only thing is they're easier to manipulate, like on a hand band, that's where you would want to use it. People can overuse these. And when I teach phlebotomy, I actually, it may sound horrible, but I have them using these, they're called monojets, they're a vacutainer device. Just pull it off, it's all ready to go, pop off the needle and go and put your tubes on.
Do you ever use straight needles to draw a patient?
Straight needles, like these,
Like a needle connected to a syringe and
absolutely. We have these that connect to syringes right here. We just screw them on, and with that, with a syringe straw and a needle, one of the things about it, and I like syringe straws, is you can actually see the blood.
Yes.
Some of these situations of blood drawing that I don't like as much, because you're either there or you're not. And you can't see it, you can't get a flash, but if you can get a flash, you know you've got it, and that's, I like that myself better.
also on babies, you don't collapse the vein, as easily when you use the, syringe, opposed to vacutainer tubes.
Yeah, and that's, and an older person, the syringe is better. And if you just have a little bit to draw, a smaller syringe will create less pressure, such as a 5 cc or 3 cc if you need a little bit. Micro tubes, you can always use if you just need a little bit, but you can create less pressure. And you know older people can have really fragile veins.
Now, another question, your CBC, do you always do a differential, or does it have to prompt you to do a differential if it's out of the normal
Okay,
frame?
the CBC includes a differential.
It includes it,
Now, what we do is we do a manual differential
okay,
if it has certain flags.
okay.
And so manually then we'll make the slide, we'll look at it under the microscope. But if they're normal or not necessarily normal, but they don't have anything that's really flagged, and that's been set by our, our staff and everything.
And one more, does your lab do the YX, the human health YX tools? I know there's, here at Northern Maine Medical Center, it used to be the nurses that did it, and they had that thing where they weren't checking expiration dates, yada, 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 so lab took that over.
Yeah, no, we handle them, some physicians like to do their own.
Right, ER.
And they may, there's a few that come get them, you know what I mean?
Yeah,
But there's also kind of over the last year or so, maybe it's been a couple of years, we actually have found, research shows that you want to keep the sample. You don't want to do it right away, so we'll do it right away for in-house patients.
correct.
But if they're outside, we'll keep them in a little baggie, and then we'll test them 3 days later, because it's actually more accurate. But in-house, they need that result right away.
Right, they're gonna be from the
Yeah.
or something.
And they don't normally do those times 3
Right.
if they can, just because you're trying to pick up blood and like a needle in a haystack. So,
Great, thank you.
any other questions? Come and see the lab.
They're very helpful. Because not only your lab, but other labs, and working in an off-site for him at a nursing home, the nurses do all the labs. In the morning, you do all your blood draws and everything, and that gets all couriered to the
Exactly.
hospital. So before, you don't know what, if you don't know exactly what to do, call them up, and they're extremely helpful.
Yeah,
Draw
say,
this
I
way,
got
draw
this
this.
person that I need to draw, I need to, can you tell me what tubes to use? Anything we're part of the same healthcare team, so call us, talk to us, come visit Now, don't try to make second guess and do it on your own first. Well, enjoy your afternoon.
Thank you.